All right. Well, as expected, that was a masterful review of achalasia. We really appreciate that. So there were a couple of questions from the audience, and thankfully we have the whole panel here. One question that popped up, Peter, you mentioned briefly about obesity, and as you know, I moved here from Texas, though obesity is now a nationwide problem. We had a series of patients with morbid obesity, with achalasia, and the reality is the diet ended up going from regular food to just ice cream all day. And so I'm curious how you would approach that. Some of our surgeons, Charu, you may want to chime in too, thought about doing a poem and then a sleeve or a Heller and a gastric bypass. Do you guys see that in Chicago?
Well, I wouldn't do a sleeve because you're doing everything there to give them reflux at that point. Yeah. But I don't know. I find it odd that this happens, that you have people who have such poor esophageal function and still get substantial obesity, but I agree it happens. I had a patient yell at me once for treating their achalasia because they got fatter, but they wanted me to take it back. So no, I haven't advocated any bariatric procedures on them. I just, I have treated them, but.
Typically, we like to do one and then the other, and again, keeping in mind the patient's real symptoms versus are they fully engaged in the bariatric sense of things, whether they're engaged in reducing weight with the lifestyle and other modifications. Those are equally important, but I agree. I think we've typically stayed away from doing both together. It's usually one depending on what they need first.
What do you guys think about Ezoflip? Kyle, you didn't mention Ezoflip in your pneumatic. I suspect there's a reason, but I'm curious what you guys think about that. That is also an endoscopic option.
Yeah, some of our colleagues across town have had some problems with Ezoflip, and so as a result, we haven't been enthusiastic adopters. Unlike EndoFlip, where we've been very enthusiastic adopters. So I think we still go in the traditional pneumatic dilation route, partially because of experience. We have experience, and as Dr. Carilla said, it's operator dependent, so you do what you know. I would be curious what you think, Dr. Carrillas, on your experience with Ezoflip.
Well, I've used it. I used it about a dozen times because initially, it obviates the need for fluoroscopy, and you can clearly image the localization of the EG junction on the device. So it gets around that. It barely achieves a 30 millimeter dilation, though. Even if you crank it all the way up, it's telling you it's only 29 most of the time. So you don't have the 35 millimeter option as a follow-up treatment. That's a real limitation. And the other thing is, the way we're spread out, and this is just a practical issue, our outpatient lab is apart from the hospital, and it's staffed by people who really aren't acute care nurses, whereas the fluoroscopy unit is in the old lab, which is in the hospital. So if you're going to go in the old lab, you might as well use the fluoroscopy. We lost the key advantage there. I'm not going to be doing pneumatic dilations with nurses who don't really have any experience in doing it, and that's what I'd be stuck with otherwise. So the place I like the device, though, is when you want to do a dilation that's between 20 and 30 millimeters. It's not necessarily in the realm of achalasia, but there are circumstances where you want to do that, whether it's a post-fundoplication dysphagia, links, something that you want to do something in between 20 and 30, and then it's a useful tool.
Another question came up. How do you guys approach those patients who get treatment for achalasia and they're still not better?
You test them.
So
everything you've got.
So is it going to be time barium? Is it going to be EndoFlip?
They're going to get the works. It's you basically do an endoscopy with a flip, you put down an HRM catheter, and then you get a time barium esophagram, and then you just look at the evidence. and make a judgment. Because, you know, persistent symptoms are more often than not up here as opposed to down there.
Yeah, I mean, I can say that as we've started to do more and more poem, I mean, one thing I've noticed that's a big discrepancy between sort of what you see in the literature and practice is these patients don't always get better. I mean, they get better, but they don't get really better. And we have to struggle with these ongoing symptoms. And that's when I send them to Kyle for neuromodulation and all that sort of stuff.
Yeah, that's where it ends up, because it is perceptual rather than function, rather than demonstrable dysfunction. And you know, they don't need more treatment directed at the esophagus. They need more neuromodulator type treatment.
And I do clarify before I send them for any treatment that all of the treatments that we offer are really directed at the GE junction, right? We are not doing anything for esophageal body physiology. And that part is still problematic in achalasia. So that part will not go away. So we just improve the outflow.
Well, apart from type 3 achalasia, where you definitely are doing something to improve the distal esophagus.
One of the points that you brought up, Peter, was about the use of Ezoflip and pneumometry, and you know, you didn't quite get there, but you sort of suggested that certainly the negative predictive value is great, the positive predictive value is pretty good too, and it seems to be getting better and better. You know, a lot out in the community, a lot of people don't have access to high quality manometry, and so are we getting to that point where Ezoflip, we can kind of use that alone?
We're getting very close. I showed you the paper on EGJ outflow that Dusty has, which is now in press, so it's available. There's another paper looking at esophageal body contractility. So it's an analysis of peristalsis, basically in the same group of 700 people. And when you combine the two, you're getting pretty close to probably not needing to do 90% of the manometry studies that get done, because they're gonna camp out in one of the two quadrants, either normal or abnormal, and those are solid. You know, it's the gray zones where you're going to end up needing to look further.
Another question, do you have a preference? You mentioned narcotics, and I'm glad you did, because, you know, I think everybody struggles with this now, with these narcotic associated motility disorders. And in those patients that you can't get them off narcotics, do you have a preference one way or another for therapy?
Botox. You know, Botox. And it's the way I generally use Botox. It's kind of like a proof of principle thing. You don't want to do something that's permanent, but you want to do something. So you kind of test the water and give them Botox. And if they do great for 6 to 12 months, then you do it again. But you will run out of agains at some point, and then you do a pneumatic dilation. But yeah.
Dr. Curtis, I have a question. Obviously, you know, you showed the difference that based on the European trial versus you know, your trial, there was a big difference in the perforation rates, and obviously one factor was to do with the balloon and the size. But obviously, we all know there's a learning curve and there's a technique difference. And my question to you, and
we had 3 centers, they had like 17.
Yeah. So I guess the question is, how do you, you know, how do you transfer the technique, especially, let's say, pneumatic dilation, in the next generation or your trainees, and how do you ensure that?
Yeah, there's not really a good answer to that, because there are only a few centers around the country that are really really teaching it at this point. And we're one of them, obviously, but we have plants around most of the country at this point. You got one over there. And then there are other ones, you know, in California and the Midwest and Texas, et cetera. They just have to go to centers that have that expertise and learn it.
I remember when that data was presented at DDW, Joel Richter made a comment that he didn't think the pneumatic dilation was done properly. That was why the efficacy was perhaps lower. And I think
That's half full, half empty, Kumar, because, you know, even if it's only 50% or 55%, that's 55% who had an in and out in the endoscopy lab and stayed for 2 hours.
Right.
And they're done.
Well, and that's a point that I can't emphasize enough as somebody who actually has shifted to POEM, and I do very few pneumatic dilations. I simply can't argue with Kyle and his point that, you know, these patients, they come in, they're ambulatory, they go out, the procedure gets covered. It's about an hour of endo time, you know, as opposed to in our center, I do all of these in the OR. So these get booked for 2 to 3 hours in the OR. They're all, we still keep them overnight. It is an enormous.
We do them in the endoscopy lab now. So
yeah.
POEMs are being done in the endoscopy lab, and they're being done outpatient.
Yeah, I mean, and certainly there are centers that are pushing that direction, but I think even regardless, the timeline for example, that type 2 patient getting a pneumatic, it's truly an in and out. And, I'm trying to, it's hard to reconcile what drove this aside from a lot of enthusiasm amongst this group of people who are interested in third space endoscopy. And without question, it has its merit and value, but I think it was very aggressively pushed because it was the latest new thing. Now it happens to have some good data behind it too, but I think there's these other factors that have really pushed into that direction. And unfortunately, the cluster of people who can now do pneumatics is going to be less and less.
We got 5 of them.
Even for teaching, we just don't have the volume to teach people. Among the people who know, we have motility fellows, and they're more rare. I know how to do them, and but they're really coming. More and more people are being direct to POEM without necessarily considering other options. So we don't necessarily have the opportunity to teach.
True.
Well, I think that was it for questions, and that's probably going to be it for our half day of the full session. We have a little bit of a break, and then we will be going to the Advanced Practice Providers course for the rest of the half day. I want to thank again all of our speakers and our keynotes speech by Dr. Karillis. I only wish we could have had you live here in Boston. But my hope
Boston tomorrow.
No, is that right? Well, for Mint 2022, you'll be here live, and we'll pack an audience for sure.
Okay, take care.
Thank you again, everyone.